Maria Kane, and I'm here with you for HIT 292, which is healthcare reimbursement. We are now on week 12. We will be studying chapter 7 in our book, which is ambulatory and other Medicare and Medicaid reimbursement systems. There's actually going to be 7 lecture videos to go with this because we have so many different ones that they gave us this chapter. If you're looking at your syllabus, you'll see we're looking at unit objectives 9.1.13 and 9.4.1 through 9.4.11 and 9.6.1 through 9.6.3. And so that's what we will be focusing on this week. This is the first video, and it is going to be on RBRVS. If you are looking at your textbook, you will see that the chapter begins on page 139. And one of the first things that we do is go into RBRVS, and that's on page 140. They're going to start us out here with our learning objectives, and these learning objectives are really going to follow us through the entire chapter, where we describe the major types of Medicare and Medicaid reimbursement systems for ambulatory services, explain common models and policies of payment for Medicare and Medicaid healthcare payment systems for physicians in outpatient settings, identify the elements of the relative value unit and the major components of the resource-based relative value scale payment system, which is what this video will be specifically focusing on. We will also, in a subsequent video, look at the elements of the ambulance fee schedule, describe the elements of the outpatient prospective payment system and ambulatory surgical center payment system. Those will be 2 additional videos. And then the end-stage renal disease prospective payment system, that'll be another video. The elements of the payment system for federally qualified health centers and rural health clinics will also be another video. And then hospice services and that payment system will then be another video. So overall, we're looking at Medicare and Medicaid reimbursement systems for ambulatory services, outpatient settings, and we're looking at it not only for the physicians who are providing the services, but the setting that they're doing it on behalf of. So, page 140 in your book, what is RBRVS? Well, it is a system of classifying health services based on the cost of furnishing physician services in different settings, the skill and training levels required to perform the services, and the time and risk involved. The relative value scale permits comparisons of the resources needed or appropriate prices for various units of service. Note this, it considers labor, skill, supplies, equipment, space, and other costs for each procedure or service. The RBRVS is the federal government's payment system for physicians and other designated health professionals. Right away, they give us these terms, and these are ones that you're going to want to make sure that you study this week. So dig out flashcards, use Quizlet, make notes, whatever helps you, but these are key terms you're going to definitely need to know, specifically when you're talking about RBRVS. So you've got RBRVS, the resource-based relative value scale. You've got relative value scale, relative value unit, RVU, physician work, practice expense, professional liability insurance, malpractice, geographic practice cost indices, shouldn't be indexes, but it should be indices, localities, market basket, conversion factor, Medicare physician fee schedule, participating physician, non-participating physician, assignment of benefits, and instant 2. Your book goes into the background here and does a really good job of going through it, so I'm not going to spend a lot of time covering that. Just note that under Part B, reimbursement for professional services includes numerous settings like physician offices, ambulatory surgery centers, hospitals, and skilled nursing facilities. Different professionals are able to bill for RBRVS, and this is a list of those. It's not just physicians. RBRVS came into being January 1st of 1992. It was a fee schedule reimbursement methodology. It was not prospective. The rates are predetermined. The services and volume of services per encounter are not predetermined. That's why it's not predetermined. And then the increased volume of procedures equals an increase in reimbursement. So make sure you know this. For RBRVS, it's not prospective. It's a fee schedule reimbursement methodology. Rates are predetermined, but services and volume of services per encounter are not predetermined. An increase in volume of procedures equals an increase in reimbursement. There are three components to RBRVS. One is the relative value unit, the next one is the geographic practice cost index, and the last is the conversion factor. Please make sure that you study this. You need to know this. An RVU, or relative value unit, those are assigned to HCPCS codes and are a measure of resource utilization. So remember HCPCS codes from CPT Part 2, and the RVU is what is assigned to that HCPCS code, and it reflects resource utilization. There are three RVU categories, and we will get into what those are shortly. The RVU categories are physician work, physician practice expense, and professional liability insurance. So make sure that you're aware of that. GPCI is Geographic Practice Cost Index. That's the adjustment for geographic differences in cost. Each RVU category has a corresponding GPCI. Conversion factor, this is the national dollar multiplier that sets the reimbursement rate. So let's talk about work, those categories, that RVU category. Work is the time required and intensity of the procedure. They're looking at mental effort and judgment, technical skill, physical effort, and psychological stress. The practice expenses are looking at the overhead costs of the practice, such as clinical and administrative payroll, office expenses, medical material and supply costs, medical equipment costs. There are two PE components. One is the facility, and the other, meaning the hospital, and the other is non-facility, which means physician office. So make sure that you're aware of that. And then medical malpractice, the cost of insurance premiums, malpractice or professional liability insurance. CMS collects data from insurance carriers and they set the MPRVUs. If you're looking in your book, we're on page 141 at the very bottom. They give you figure 7.1, which talks about the foundation of the resource-based RBRVS, and they show you under step 1. You've got your work RVU plus times your work GPCI, your practice expenses RVU times your practice expense GPCI, and then your PLI RVU times your PLI GPCI. And then you multiply that against a conversion factor, and that gives you your payment modifier, and that ends up being the adjusted fee schedule payment rule, or rate. So category percentage of total RVU. The biggest RVU is actually work, followed by practice expenses, and the smallest slice of the pie is medical malpractice insurance or that professional liability insurance. GPCI is based on locality or payment areas. It can be a large metropolitan area or portions of states or an entire state. There is one GPCI for each RVU category, meaning work, practice expense, and malpractice insurance. The conversion factor is set prior to the start of the rate year and remains constant throughout the year. They give you calendar year 2018, but I'm sure you could go out to the Federal Register and find calendar year 2020 and find this conversion factor. So how do you calculate RBRVS? It is the work RVU times the work GPCI plus the practice expense RVU times the practice expense GPCI plus the malpractice RVU times the malpractice GPCI, and that gives you a sum. You multiply that sum by the conversion factor, and that gives you the Medicare physician fee schedule amount. Third-party payers who utilize RBRVS for reimbursement modify the system to fit their own needs by modifying that conversion factor. So just keep that in mind. This is an example here. This is for CPT code 99202, office visit, new patient, expanded problem focus. So that CPT code, you can see, has RVUs, GPCIs, and it gives you a product, gives you the sum. You take the sum times the conversion factor, and again, they're using this from calendar year 2018, and that gives you the total amount. This is the cost sharing. And we are now up to, trying to look where it says about cost sharing. Anyway, this just shows you the Medicare piece and the beneficiary piece. And I believe that that's typically it's 80-20. In your book, figure 7.3, example of Medicare beneficiary coinsurance portion, that's what this is supposed to be. They show you that 80-20 split. And the larger portion is 5813, the smaller portion is 1453. There is a lookup tool that you can go out and use to help you figure all of this out. There are potential adjustments. Clinician type. Is the clinician participating or non-participating? And the rates are adjusted for non-participating providers. You can look in your book here. Table 7.3 versus table 7.4 will give you some examples there. Anesthesiologists have a separate unique payment system under RBRVS. It utilizes base units for anesthesia services, time intervals, and conversion factors. And that's shown in table 7.5 on page 145. Then you have non-physician providers like clinical psychologists, nurse practitioners, physician assistants, and those get 85% when not incident to nor under the direct supervision of a physician. And the example they give you of that is table 7.4. When you look at non-par physician, special circumstances, when there's a bilateral procedure, it's lesser of actual charge or 150% of the MPFS amount. There's multiple procedures. The first procedure is always paid at 100%, the second to the fifth at 50%, sixth or more requires review. And then physicians that are assisting surgery get 16%. Make sure that you know about the bilateral procedure and the multiple procedures when it comes time for your quiz. Through the RBRVS payment system, CMS provides an incentive for physicians to render services in underserved areas. The purpose of the incentive is to attract physicians to these areas, and so CMS makes bonus payments to physicians who render medical care services in underserved areas. And this information's on page 146. They get a 10% increase. There are some operational issues. Many offices are solo or two-person practices, so there's close management of the operations needed, and they have to have processes to ensure full and accurate reimbursement, impact of unnecessary administrative costs. Obviously, correct coding and good documentation are crucial to reimbursement. And on page 147, it shows you a comparison of the impact of coding on non-facility reimbursement under RBRVS. And table 7.7 shows non-facility revenue loss from incorrect coding or incomplete documentation under RBRVS. So it shows you how there can be payment losses. And then table 7.8 on the top of page 148 shows a comparison of Medicare payments by category of site and by selected years, just to give you an example there. And this is highlighting the importance of documenting and abstracting service location. Impact of unnecessary administrative costs. Well, time spent on administrative details for multiple health plans can absolutely create administrative costs. An Institute of Medicine report from 2009 talked about $190 billion. So you can see excess administrative costs are astronomical. An administrative cost rate of about 20% for private insurers is not uncommon. Medicare tries to keep it around 2%, or at least they did. This was all published in 2018, so it's probably higher than 2% today, but you can see there's a big difference between administrative costs for Medicare versus private insurers. That is it. We're going to stop here with video number 1. I will be back with video number 2 in just a minute, and we will be talking about ambulance fee schedules. So hang on.